Okay, so we're going to get started. Good evening, everyone. My name is Quinn Sue. I'm a periodontist practicing in Mississauga, Ontario, and I will be your host tonight. It is my pleasure to welcome everyone tonight to the OAK Seminar Series presented by the Graduate Specialty Program in Periodontics at the University of Toronto. The seminar started in the fall of 2020, and we've been humbled to see such strong interest from many domestic participants, but also participants from around the world, such as Egypt, UK, Australia, just to name a few. So some housekeeping points. This presentation will take about an hour, followed by a 30-minute question and answer period. And tonight's Q&A will be moderated by U of T's residents, Dr. Lelia Finnan, Dr. Chris Stair, and Dr. Sean Robinson. So please direct all your questions to the moderator tab. Okay, let's get started and get to tonight's exciting program. We are so excited to welcome Dr. Wong to our platform. Dr. Wong is a board-certified periodontist in private practice in Tulsa, Oklahoma. Dr. Wong received his undergraduate education and dental training at the University of Oklahoma. He then went on to complete a 3-year residency in periodontics at the University of Missouri, Kansas City. He is a diplomat of the American Board of Periodontology, as well as a fellow of the International Congress of Oral Implantologists. He is a published author in several peer-reviewed dental journals, but has also reached a mainstream audience in media such as Fox News and the Wall Street Journal. Dr. Wong presently resides in Tulsa with his wife and his 3 children, where he maintains a full-time private practice. So I will pass on the virtual mic to Dr. Wong to begin the presentation.
All right, just give me a second here to pull everything up and we will get started. All right, so here we are. All right, so the title of tonight's presentation, it's going to go for about 1 hour and 15 minutes. It's entitled Soft Tissue Management Around Teeth versus Implants. And I'm delighted to give you all this presentation. I actually gave this at my first live meeting in almost a year last week in Arizona. So it's nice to be able to do this, the full version of it with you all virtually tonight. So thank you for your attention and the invitation once again. So when it comes to grafting, soft tissue grafting around teeth and implants, we're going to start off tonight just talking about the differences between the two. Sometimes we handle recession defects like you see here on teeth versus implants. We handle them just a little bit differently. So I was just going to walk you through some of the rationale behind the treatment that I recommend. It's just a quick view of our reception area here in Tulsa, Oklahoma at my practice. And for those of you all who don't know me, I'm pretty active on Instagram with social media. So if we don't get to your questions tonight, just send me a message at any one of these accounts, either david.long.dds or at Plaque China, and I'll get your questions answered. So the goals for today. I want to identify the differences between mucogingival deficiencies between teeth versus implants. We're going to review just common graft materials. I know there's a ton of different ways to do things. So I in no way, shape, or form claim to have the answers for everything or that my way is the only way. But we will review some common graft materials and some common flap designs that I like to employ. And then we'll talk about the rationale for various techniques to correct soft tissue defects around teeth and implants. So we've all seen this diagram before. When we look at teeth versus implants, they're quite different, of course, not only in the way they function and in the way they perform, but mainly for me, the big difference is how we treat them when it comes time to treat soft tissue defects. So as we all know, implants do not have a periodontal ligament. The connective tissue fibers are oriented parallel to the surface of the implant versus on a tooth. They're more perpendicular to the surface of the tooth. So we have little things like that, but I'm going to walk through kind of the more gross differences instead of the little histological differences. So we'll talk about that throughout the talk this evening. So when we look at mucogingival defects, and this is kind of where I like to start the show. When we have recession defects on number 24, 25 natural teeth versus recession defects on 24, 25 implants, do we treat these the same? And that's just kind of the question that I want to start off asking, and we'll dive into the answers shortly. What about on upper teeth? On incisors, do we treat recession defects on natural teeth versus implants the same way? What are the rationales for why we may treat them differently? So let's start off with how I go about treating teeth. When it comes to treating recession defects around teeth, whether we call it mucogingival surgery or periodontal plastic surgery or oral plastic surgery, pretty much interchangeable for me. But basically what we're trying to do is correct abnormal gingival mucous membrane relationships. We can perform them as an adjunct to treating periodontal disease or independently for the purpose of giving us a better mucogingival situation by widening the keratinized and attached gingiva. So the rationale behind mucogingival surgery is the idea that we need 2 millimeters of keratinized gingiva with 1 of those millimeters being attached as a requirement for optimal gingival health. I know there's some debate about that, but generally speaking, we all generally accept that we need 2 millimeters of keratinized tissue and 1 millimeter attached. You may have reduced, inadequate, or absent attached gingiva for several reasons. You might have periodontal disease where the perio pocket extends apical to the mucogingival junction. You may have high freedom pulls in the area. And of course, what I like to talk about the most, which is gingival recession, where it exposes the root surfaces or implant surface. So what are we trying to fix exactly? What we're trying to fix, of course, is the quality of the surrounding tissue. We want more keratinized and attached gingiva. We also want to eliminate high freedom attachments because they kind of go hand in hand. Usually you have a high freedom attachment at the same time as you have thin facial tissue and non-keratinized or unattached mucosa. So we also want to correct gingival recession to establish more ideal gingival contours. So when we look at situations like these two teeth here, we have recession defects on the lower incisors. You can clearly see that there's a high freedom attachment, no keratinized or attached gingiva. So what exactly would you do? So the first thing for me, especially whenever people like to message me cases and send pictures and radiographs and things and ask me my opinion, I always tell people the most important thing about oral plastic surgery is case selection. And in order to select the proper case, we need to classify it. We need to, and obviously there's lots of different classifications for recession. I still am a little bit old school, so I use Miller. So Miller's classification. The only thing I want to add for those of you who don't know is that class 1 and class 2 Miller recession defects, the big thing with them is that there's no interproximal bone loss. And that's going to be the key thing in our success, is that if as long as we have a recession defect that does not have any associated interproximal bone loss, we can get up to 100% root coverage. And that's a good thing. The difference between class 1 and class 2 is whether or not the defect goes to the mucogingival junction. And in the class 1 Miller defect, the recession does not reach the mucogingival junction, whereas in a class 2 it does. The big jump in our predictability or big decrease in our predictability is going to be the difference between class 2 and class 3 recession defects. The big difference here is because class 3 defects involve the loss of the interdental bone or interproximal bone. And that unfortunately limits us to 50 to 75% root coverage. Class 4 is where nobody wants to be, and that's where the recession extends beyond the mucogingival junction. We have such a severe interdental bone loss that it actually extends apical to the recession. So in a situation like that, all we can do is hope for an improvement in the biotype of the surrounding tissue, improve the thickness, but no root coverage is really expected. So big thing here with this slide is, where is the bone? The more bone you have, the better your chances of success, no matter what technique we're talking about. So going back to this same area, what are the treatment options for gingival recession on lower incisors? Does your thinking change when we look at upper incisors? So for me and for brevity's sake, for today, we're going to make the argument pretty simple. We're either going to talk about free gingival grafts, connective tissue grafts, or acellular dermal grafts. So one of the three. So as Benjamin Franklin said, is if you fail to plan, you're planning to fail. So everything starts off with a good plan. So questions that we should ask ourselves anytime we're encountered with these recession defects is simply, what are the goals of treatment? Is the patient looking for improved comfort or function? How long do they want their procedure to last? Does predictability matter to them? How much do they value oral health? Is aesthetics a concern? For me, I like to ask myself, can I get root coverage predictably? Do I need more keratinized and attached gingiva? Is the area technique sensitive? So things that would determine technique sensitivity is going to be the root proximity of the teeth, the papilla size, vestibular depth, frenum pulse, tissue thickness, and things like that. The reason that is important is because it's harder to work in between roots that are smashed together, as in the lower incisor area. Smaller papilla are harder to work around or work with than larger papilla. Vestibular depths, we all want a deeper vestibule than a shallow vestibule. And of course, nobody likes working in the presence of frenum pulls if we can help it. So the theme, one other theme of today, when we talk about tissue management, if you guys have heard me speak before, you know that I like to be more clear on my terminology. And I sometimes don't like the word or phrase soft tissue management, because management to me is something where we have control from start to finish. Whereas we'll talk about this more when we talk about recession defects and implants. Whereas some of these cases with implants, we're talking more about rescue, and we'll talk about the challenges that we face when we're making the distinction between soft tissue management versus rescue. So with free gingival grafts, that's where I want to start with natural teeth. That's often the solution for me to address the recession on lower incisors. And why is that? The big reason for me is because, number one, it's very, very predictable. I know we have some perio residents watching today, and I can tell you, and they can tell you, free gingival grafts are one of the most predictable soft tissue grafting techniques that we have. It's very, very simple. It's not technique sensitive at all. It's the one procedure where you get the most predictable, massive gains in keratinized and attached gingiva. It addresses frenum pulls at the same time. The main downside is going to be the root coverage is not always so predictable. That's the bad part. But once again, this is something that we talk with our patients about before we ever get started. So when we look at the other advantages of free gingival grafts, the suturing is very, very simple. The graft can be placed on the bone or the periosteum, doesn't really matter. And then, of course, the apical and lateral borders of the graft, you can leave them unsutured if you want to. You can do like I've done here with the periosteal anchoring suture, or you could leave it out. There's just a lot of different options for us here. So once again, for lower incisors, when root coverage isn't the most important thing, but changes and improvements in the tissue quality and thickness are, I go free gingival graft all day. Huge gains in keratinized and detached gingiva. The frenum is the non-issue now. And you'll notice that we have stability despite poor oral hygiene. So going back to this case here, you know, for me, a lot of people would consider connective tissue grafts in lieu of a free gingival graft. But for me, I think the free gingival graft accomplishes more of my goals than a connective tissue graft would. Here's another free gingival graft. So where do connective tissue grafts come into play? Certainly, they're very, very popular. We do them all the time. So when would we use a free gingival graft versus a connective tissue graft, or a connective tissue graft instead of a free gingival graft? So as an example here, we have a little bit of recession from number 22 through number 26. And I'm sorry, I'm brain farting a little bit on the numbering systems, but for our system, number 22 through number 26. We'll just take a connective tissue graft from the palate, and I'm going to show a short video later on how I like to do that. And what we do is we'll just suture around the lower incisors and suture it together. Now, the difference here between a connective tissue graft and a free gingival graft in this area is going to be that the frenum pull isn't as strong. The tissue is already more adequately thick. We didn't have a whole lot of inflammation and edema in the tissues. So connective tissues work great when root coverage is important, okay? The neat thing about connective tissue grafts is we don't have to we don't have to completely cover the graft material. You can leave a little bit of it exposed. As a matter of fact, some people prefer it that way because the exposed part becomes keratinized tissue. So here's our before and here's our after. Now, when you look at the after here compared to what I showed you earlier with a free gingival graft, you're going to notice that the frenum pull is addressed, and it's certainly less prominent, but it's certainly still there. Compared to a free gingival graft, it's often not there or very, very apically positioned. You'll notice that the color matches better with a connective tissue graft compared to a free gingival graft. And we also get more root coverage with a connective tissue graft as well. So there is no right or wrong necessarily when it comes to addressing these recession defects in the lower incisor area. It's just a matter of what the goals are. So to summarize, free gingival grafts offer less predictable root coverage compared to a connective tissue graft, but they have the advantage of a larger increase in keratinized and attached gingiva. If we're trying to address the frenum attachment, the free gingival graft is the way to go. FGGs are also less technique sensitive. Now, as far as versatility though, the connective tissue graft lends itself to more versatile flap designs than a free gingival graft does. With the free gingival graft, you're pretty much just doing a full or partial thickness bed preparation. You're removing the overlying flap, which is just all thin, unkeratinized, unattached tissue anyway. But with the connective tissue graft, it's a little different. So we get to do things with connective tissue grafts such as envelope flaps or tunneling procedures or alternating tunneling, papilla tunneling procedures. We have lateral sliding flaps that I'm going to show you. And then of course we have the traditional coronally advanced flap. So the connective tissue graft offers more versatility when it comes to flap design. So if you like lateral sliding flaps, just a shameless plug here. I did write chapter 11 in this textbook, Advances in Periodontal Surgery, written by my friend or edited by my friend, Dr. Salvador Nariz, who put together a lot of people to contribute chapters, and I was honored to be one of the contributing authors. But anyway, when we do connective tissue grafts and lateral sliding flaps, so this is one of those situations where we have 7 millimeters of recession on the mesiofacial root of number 14, the first molar. There's lots of different ways we could do this, but one thing you'll notice is that we have a lot of keratinized tissue on the tooth next door, which is actually a pontic. So why not just borrow that tissue. So in a situation like this, like I said earlier, with that much root exposure, a patient and you are probably going to want some root coverage. So a free gingival graft is not something that I would want to consider. A coronally advanced flap with a connective tissue graft, though, that's a really long ways to move the tissue coronally. And not to mention, by doing so, that would shorten the vestibule quite a bit as well. So one of the things that we considered here was just doing a lateral sliding flap, and this is what you see. So from the left to right, you're just seeing the flap, the lateral sliding flap is being prepared. So we're going to slide it over from the number 13 pontic site over to the first molar. We're going to grab our connective tissue, like you can see here, suture up the palate, and then we're just going to suture that over the mesial buccal root of number 14. The center photo is taken at the 2-week suture removal, and then we have a final outcome at 6 months on the right side. So with connective tissue grafts, you get way better root coverage. You have more flap designs in your bag that you could use. But what about acellular dermal grafts? What do we do about those? So going back to the lower incisors again, just to try to compare apples to apples as much as we can. ADGs such as perioderm, alloderm, dermis, and a number of other materials can be considered when patient morbidity is a concern. So maybe a patient's on a lot of medications, or they just are very, very fearful, or maybe they have bleeding issues in the palate that they're worried about, or maybe their palate isn't a good palate. Maybe there's a palatal tubercle or a large tori in the area. So those are some things to consider to where you may want to use an acellular dermal graft instead. Patients do love avoiding the second surgical site because it cuts their pain and morbidity down quite a bit. So where we would use, or I would use, an acellular dermal graft would be when the marginal tissue is already adequately thick. You can see here that the tissue is already thick and pink and healthy. We just have root exposure. So in a situation like this, it's perfect for an acellular dermal graft. Here we're using a product called perioderm. So as you can see here, we tunneled underneath the papilla in the lower incisor area, but we've done traditional coronally advanced flap designs for the premolar and canine. So the graft is sutured into place, and then we advance the tissue coronally to cover the acellular dermal graft material. It's important, unlike with the connective tissue graft, it's important that the perioderm or any acellular dermal graft is completely covered. There are some materials where they'll say that you don't have to completely cover it, but it's always a good idea to completely cover it to avoid any graft necrosis and things like that. We also want to make sure at the end of the procedure that we tug on the lower lip, move it up and down and laterally to make sure that there's no tension in the flap. Here's a 2-week post-op. Sutures will come out at 2 weeks for me. Some people wait longer. I'm not thrilled about the canine, but it's not terrible, especially when you look at it 1 year later. The results are pretty decent considering we used an acellular dermal graft. In a perfect world for me, I would always use autogenous tissue if a patient's willing and I can do it. So the bottom line for natural teeth is that in the mandibular incisor area, free gingival grafts are favored in my opinion, especially the lower two incisors. I like to do free gingival grafts whenever I can, especially if orthodontics is going to be part of the plan, because nothing beats keratinized and attached gingiva for this area. And oftentimes, aesthetics is not really much of a concern. With maxillary teeth, it's a little different for me. With upper incisors and canines, especially if they have adequate marginal tissue, for me, I'll just tell you, use whatever your favorite graft material is. If it's Autogenous tissue you like, great. If you like acellular dermal grafts, great. It's going to work. The reason that works is because upper teeth typically have a deeper vestibule, really not any frenum pulls to really mess with. Big prominent papilla, usually the tissue's thicker. So choose your favorite. In a situation like this, root coverage, keep in mind, is going to depend on the level of the interproximal height of bone. That's going to determine how much root coverage you get. To answer that question too, by the way, a lot of people ask, I usually determine the interproximal height of bone radiographically. So assuming we have a well-angled radiograph to diagnose, I like the interproximal bone to be about 1.5 to 2 millimeters apical to the CEJ. So if that's the case, then I'll consider that no bone loss. So in a situation like this, we have anywhere from 2 to 4 millimeters of recession, and we have adequate keratinized and attached gingiva, gigantic papilla to work with. So I like to use the acellular dermal graft in the situation like this. Lots of people like to tunnel. For me, I like to tunnel the papilla, the central papilla, underneath the midline, because that's the one where I don't want a black triangle. Everywhere else, if we have class 1 recession where we have good interproximal bone, you can reflect the papilla and manage the soft tissue to where it will grow back without any black triangles being a concern. So here's the final result here. Here's the before and here's the after. So let's just switch gears and let's talk about implants. So with implants, it's different, a lot different. For example, in all these cases that you see here, we've got a combination of exposed abutments. We have some threads exposed. We have malpositioned implants that are put too close together. We have thin tissue. We have frenum pulls. We have everything that we had with teeth, except now we have to deal with a metal surface or a ceramic surface. So that could be a huge issue. So what I'm going to remind everybody, I have not invented anything. I've written a few chapters in books and things like that, and articles, but I have not ever invented anything. I wish I was that smart. So I always say I not only use all of the brains that I have, but all that I can borrow. And I can tell you for this presentation, I have borrowed a lot. So 4 factors affecting implant aesthetics. So when we talk about dental implants, we're usually not talking about osseointegration much anymore. We're really talking about implant aesthetics and how we can get implants to look like natural teeth. So that's going to depend on 4 factors. One is the existing gingival levels. Patients will come with their own pre-existing gingival architecture that may or may not involve teeth or implants. So we're kind of stuck with what we have unless we decide to change it. Of course, the tissues and the bone will respond accordingly to how we manage the soft tissue and how we manage our implant surgery. Obviously, every time we touch the patient surgically, there's going to have some associated trauma, and how they recover is going to affect how the soft tissue appears. Another factor affecting implant aesthetic is going to be the position of the implants. Sometimes implants are just not placed in a very good position, and we have to make this a very tough decision on whether we keep the implants or take them out. And then finally, being a periodontist, I know I have a lot to do with how the tissue looks, but a lot of how things look also have to do with my restorative dentist. So management of the tissue with the abutment and the crown is also important. And I put this small case, if you can see it here, because choosing the proper abutment and crown and designing the proper contours and things like that will really affect the appearance of the restoration. So just to remind you that surgeons can do a lot, but restorative dentists have a responsibility there too. So the big difference between teeth versus implants. Implants have a metal surface. It's a gray, ugly metal surface. It shines through the tissue. It can be exposed if the implant's placed in the improper position or if the tissue's too thin. Interproximal bone levels, which I told you is like the most important thing in determining root coverage or implant coverage, that's a lot. It's worse on implants, right? Because of where we place the implants. Sometimes we countersink them, sometimes we don't. But anyway, we have crystal bone loss to deal with. There's lots of things that put us at a disadvantage when treating implants. Papilla size is often smaller around implants, and I told you earlier that smaller papilla are harder to work with. And then when we look at the CEJ, of course, implants have a fabricated CEJ depending on where we put the implant. So I would say, given the choice, I would choose to treat or graft teeth over implants any day. So going back to my definition of soft tissue management, what is the definition of management? Management means controlled direction. My question to everybody is this controlled direction? Are we in control of this case at all? I would say we're not. This to me is more like rescue. What is the definition of rescue? Rescue is to free from danger or distress or to recover. So sometimes when we're given these cases, we're just trying to recover, trying to save face. And that's the best we can hope for sometimes, but let's see what we can do to help. So here's a case that I treated. Tooth number 8, endodontic treatment was initiated and then aborted once a hopeless prognosis was determined. This case came to me from an oral surgery colleague of mine who did a bunch of bone grafting, was successful at placing implants for the central and lateral incisor, but you can see how the soft tissue reacted, and you can also see how deep the implants were placed. So in situations like this, these are two different situations. One is management, the other one's rescue. Okay, so how do we fix these problems? So there's 4 rules of soft tissue management that I like to follow. Number 1 is have a plan. Once again, if you fail the plan, then you plan to fail. Number 2 is going to be know your biology and let it work for you. So when we look at the case on the left with tooth number 8 versus the case on the right with tooth number 9, these are 2 totally different cases, okay? Not literally, I mean, they are 2 totally different scenarios. In one, on the left side of your screen, we have different tooth morphology, which is more short and square. Whereas on the right side, we have a long tapered tooth morphology. Which one would you rather treat? Hopefully, if you're watching, everybody picks the tooth on the left. We want to treat number 8, the short square tooth, because the papilla are wide and short, whereas the papilla on long tapered teeth is very tall and skinny. I'd rather have short fat papilla than tall and skinny papilla, because as you can see on the right, we already have a black triangle between the 2 central incisors. So know your biology and let it work for you. Don't forget, when you're treating teeth, we have things to fix or address the interproximal height of bone, such as orthodontic extrusion. We have things to protect the facial plate, such as the partial extraction therapy. And then, of course, we have the option of minimizing damage to the facial plate by grafting, soft tissue grafting at the time of implant placement. So we have other things at our disposal that we can do before surgery, before the implant's placed, at the time of implant placement, and even beyond that. So consider all your options before you get started. Number 3, I like to graft early. So being a periodontist, I like to put my soft tissue grafts on pretty early, and I'm going to show you a couple cases why and how that's worked out for me. So in cases like this, I like to graft. I like to do the soft tissue graft early. Other people would disagree, and that's okay. Some people like to do the ridge augmentation and grow the bone first and then do the soft tissue later as needed. But for me, and I'll present to you why in a minute, I like to have soft tissue first. Number 4, be patient with restorative treatment. So if you haven't already done so, invest in the knowledge and training into how to make customized healing abutments and customized impression copings. So as an example, on the left, we have just what the soft tissue looks like when the healing cap is removed versus the one on the right where we've made a custom healing abutment and it's been removed. So you can see that soft tissue is much more natural and more anatomically correct when we use a customized healing abutment. So that's a no, and that's a yes. So let's go through a management case. So this is the case that I just showed you. It's tooth number 9. You can see a horizontal root fracture across the tooth, have a fairly short root. There's a periapical radiolucency and a periodontal defect on the mesial aspect and some horizontal bone loss on the distal aspect. So these are what we're dealing with. And once again, we don't really like long tapered teeth with pre-existing black triangles anyway. They scare me, and they should probably scare you too, honestly. So here we have have her smiling photo. Once again, long tapered teeth, prominent papilla, dark triangle, and a high smile line. So whenever I say a high smile line, I like to go by Dr. Stephen Chu's definition, which is the presence or absence of the visibility of the papilla, not necessarily the zenith of the gingival margins. I like to look at the papilla. So in the papilla, in the smile, the papilla show 87 to 100% of the time. And keep in mind that there is a suggested papilla size too, which is 40% of the height of the teeth. So those are Chu's guidelines in his paper here. So for tooth number 9, started off with an atraumatic extraction, relatively atraumatic extraction, because we've kept the soft tissue mostly intact. Here, what I've done is, and this is just to think outside the box a little bit. Once again, lots of things that we could have done, but this is something that I found really easy to do. And this is what I teach the residents that I teach whenever I'm in the clinic with them. So it's a composite graft here where we're going to do a basic socket graft, but then we're going to go to the tuberosity, get a trephine, and drill out a core of a composite graft consisting of autogenous bone with some tuberosity tissue. So the reason I call it a composite graft is because it's a composite of autogenous tissue with the allograft at the apical portion of the socket. And then we'll use the tuberosity tissue, which is stuck to the autogenous bone, as a socket seal graft. And this is called a modified socket seal graft, as published by Dr. Carl Misch. Craig's on the paper, but it's Carl that's first on that paper. So after 3 months, we go to our surgical planning phase, and with central incisors, I generally try to go flapless with our implant surgery. So here you can see that the defect has been corrected on the mesial aspect of number 9. Here's our surgical treatment planning. We're going to follow the 3-2 rule as outlined by Dr. Lyndon Cooper. And the 3-2 rule is this: you want to place your implant for central incisors 3 millimeters in a coronal apical direction, 3 millimeters apical to the gingival margins of the adjacent teeth, and you want to place it 2 millimeters lingual to the facial plate, which essentially puts you into the cingulum of the tooth. So here is the implant placed, and a healing abutment's been placed on top of that, but you can see the perio defects corrected. And then after a few months, we'll put a provisional restoration on. Now with the provisional restoration, everything looks good, but what you're going to notice, at least hope most of you probably have noticed, there's a large dark triangle that's developed between 8 and 9 despite atraumatic extractions, a composite graft with the soft tissue modified socket seal. So this is what she looks like. And once again, if you look, this is where Dr. Chu's paper on smile aesthetics is really important. So you can see even in that middle picture, she would have what we would traditionally call a low smile line, but we can all see that the papilla is gone. So one of the things that we often do as dentists is we freak out and we want to try to fix something, right? We want to get out our hand pieces or our scalpels and try to fix something. But if we look at the science and wound healing of people, we know from Yuli Grunder's papers, this is a pretty popular paper, that the papilla volume increases an average of 0.375 millimeters after 1 year. Other papers will say about half a millimeter. So anyway, you're going to get an additional half a millimeter just by doing nothing. So this is what she looked like at 2 years with the final restoration on. So preoperatively, you can see the papilla. By 4 months with the provisional, it's gone, but by 2 years, and by the way, this looked the same at 1 year, but by 2 years when she came in for a post-op visit, you can see that there's hardly any difference at all in the papilla from pre-op to 2 years. So for me, this was more management. We're designing the surgery, designing the restorative phase from the very, very beginning. Nobody is dictating, what or when we do it. We're not handcuffed by implant positions and things like this. So that's soft tissue management. So some of these other cases are more along the lines of rescue. So before we get to that, let's talk about more management here. So here's a case where the patient is missing the lower right central and lateral incisor. You can see that there's a huge defect horizontally as well as vertically, but mostly horizontally. You can see the patient's going to require a pretty hefty ridge augmentation. The question is always, when do you do it? So before we answer that, I like to ask, how important is it that we have adequate keratinized tissue around our dental implants? For me, it's very important. The reason it's important is because in my experience, and the majority of literature supports this, is that with keratinized tissue around implants, you get less inflammation, less bleeding, less plaque, less recession, and less bone loss. When we look at the studies on overdentures, these assumptions are confirmed. When you have less than 2 millimeters of keratinized gingiva, you do have more recession, more bone loss, more plaque accumulation, more inflammation, and more bleeding upon probing. So we know that happens with overdentures. Now, when you look at systematic reviews, though, and this is from some friends of mine, I see Gustavo Avila Ortiz on this paper. They, in a systematic review, found that having less than 2 millimeters of keratinized gingiva, they were inconclusive. They did not have enough information or enough papers with the same criteria to determine that not having enough keratinized tissue really affected marginal inflammation or probing depth or bleeding on probing. Here's another paper that had no conclusion, which was another prospective study. But what they did find, though, was that patients report equal comfort levels with or without keratinized tissue, but they preferred the appearance of having keratinized tissue around their implants, which I think is really important. And that's going to play a role here in a second. The other thing I wanted to note from reading this paper is that oral hygiene was impeccable. It was immaculate, perfect. So if your patient has perfect oral hygiene, then yeah, maybe they don't need a whole lot of keratinized gingiva, but I would say in my practice, hardly anybody has very good oral hygiene at all. So just a collection of 12 studies here. I just wanted to point out that in the 12 papers that I read, there's 6 of the papers where pro-keratinized gingiva is important for oral health or implant health, and 6 were no's or maybes or not enough information. What about gingival biotype? Is that important? So biotypes are I love this category. It's easy. It's either thick or thin. So when we're looking at biotypes, we once again assume that with thicker gingival biotypes, we have less recession, less inflammation, and less bone loss. But what I like about having a thicker gingival biotype is, especially when it comes to ridge augmentation procedures, you have improved vascularity and graft stability for your bone augmentation procedures, which for me, I need all the help I can get. Once again, it also looks better when you have thick keratinized gingiva around your implants. Last thing we want to look at is how important is the vertical gingival thickness. So when we look at this is after you place your implants, another friend of ours, Dr. Thomas Linkevicius from Lithuania, looked at the importance of gingival thickness in a vertical dimension, not the horizontal dimension, but the vertical dimension. They determined that the more thicker tissue above the implant led to less crestal bone loss. So not only are we looking at the importance of keratinized gingiva, we're also looking at the importance of a thicker biotype, both in the horizontal as well as the vertical dimension. So we want a lot of tissue. This diagram on the right side is just something that I've come up with just to outline how many different directions we can go with just 3 different types of soft tissue grafts. So the end, even with 3 types of graft materials, by the time you talk about blood supply, grafting techniques, and flaps and things like that, you have so many different combinations that it can get a little bit confusing. So I just want to run through just a couple basic scenarios for you. This one is in a different chapter that I wrote from Dwayne Keratinized. It was in Implant Aesthetics. I can't remember what chapter is mine there, but it's in there. So when it comes to soft tissue management around implants, I always tell my patients who come in with these problems, the biggest thing is getting them back to health. You don't want bleeding tissue or inflamed tissue because that's going to be harder to maintain. It's going to lead to even more recession and more bone loss. So we want to get them back to health. And then, of course, we want them to be back to being comfortable and able to eat the things that they like to eat, brush when they want to brush without pain. With comfort comes function, and then, of course, lastly, I try to seek a solution for the aesthetic dilemma. But the first things first, which is health. So in a situation like this, I can see that, even if we do the ridge augmentation and the implants, my feeling is that we're going to leave this patient with not a whole lot of keratinized tissue on the facial aspect. So that's going to be a problem for her later. And it's been my experience that by the time people are done with bone grafts and implants and final restorations, the last thing they want to do is a free gingival graft or any type of a soft tissue graft. So that's the other reason that from a practice management perspective, I like to do that part early. So when we look at Jay Siebert and Henry Salama's paper, they also advocated when doing ridge preservations and reconstructions to graft soft tissue graft early. So to remind you, thicker gingival biotypes lead to less recession and inflammation, but because we need a ridge augmentation later, it's going to help with the vascularity and stability of the graft. So here what I've done is I've taken a very thick free gingival graft from the palate, and we're just simply suturing it over the facial aspect where that horizontal ridge deficiency is. This is what it looks like at the suturing 2 weeks later when the sutures are removed. And then just for sake of time, we placed 2 implants with a 3-unit bridge. We ended up sacrificing the tooth number 24. And you can see the 2 implants with the 3-unit bridge. This is 8 years later, so you can see how healthy the soft tissue looks. Obviously, this is in the lower incisor area, so the free gingival graft is not an issue aesthetically. If this was a maxillary tooth, maybe we'd do something different, but maybe we wouldn't. We'll see. So how do you manage a failed implant site? So this gentleman came in because his implant, after only 2 years, became exposed in the middle part of the implant. So it has a fenestration in the soft tissue. Surgeon is a good friend of mine, but he only does oral surgery. So he was like, "Can you help me out?" So in a situation like this, we really have to figure out, number one, are we keeping the implant or are we going to take it out? Because of that, the soft tissue exposure, obviously there's no bone around the implant, so we opted to take it out. But in a situation like this, when do you address the soft tissue? Once again, for me, rule number 3 is graft early. So this is what the implant looks like in the facial position. We took the implant out, but we also put the free gingival graft on at the very same time. That way we can be a little productive. And as the osteotomy is healing, the free gingival graft can be healing as well. So this is what it looked like at the time of the procedure. You can see on the palate where we took the graft. And then here's our 2-week post-operative checkup here. Next is going to be time for our ridge augmentation. So we're utilizing our cortical perforations into the facial plate. This is what it looked like from the occlusal view as well. We're putting in a tenting screw to aid with graft stability and space maintenance. We got some PRF from the patient so that we could use our mix it with autogenous bone to make some sticky bone with an allograft and xenograft as well. So we have a nice little cocktail in here. So we have a xenograft, we have an allograft, some autograft, and PRF. So we've got a nice thing of sticky bone here. And as you can see, when we place it, it's nice because as far as handling, the handling of the sticky bone or steak bone works really, really well. We're going to cover it with two membranes, suture it down, and then simply close. So in this manner here, I think the key is to do a free gingival graft to help with the soft tissue management. I think it helps really, really well. But number 2, you do want to make sure that you don't extend your free gingival graft too far apically, because you still need to have good closure when you do your ridge augmentation. So here what we're doing is just placing our implant. This is the guided plan. We planned for a BioHorizons implant in a situation like this. And after we place the implant, scan body goes on. That way, whenever we uncover the patient later on, we can put a provisional on at the same time. Obviously, he has other dental work to be accomplished. So my rule when it comes to stuff like this is we wait for all the teeth to be restored at the same time. So this is this gentleman right now with my provisional on. Okay, so that's managing a deficient ridge as well as a failed implant. So now what do we do about existing mucogingival issues around implants? So let's go to this central incisor case that I showed you earlier. We have 2 implants, and I will say that I did place both of these implants. I placed them a long time ago. Don't know if I would do it exactly the same way like this again. Probably I would go with narrow diameters, and I would probably do a better job with addressing the bone instead of just putting the implants where the bone was. But this is it. Anyway, this is what I did a long time ago. So now the patient comes back a few years later and has a lack of keratinized and attached gingiva. There's a high frenum pool. Once again, implant sizes may have been too big, probably too close together, and there might be some parafunctional activity as well too. So a lot of different factors, and now we have to deal with a mucogingival defect as well as some exposed threads, implant collar, and some abutment as well. So going back to the debate, do we do a connective tissue on the left side or do we do a free gingival graft? So let's look at what we're trying to accomplish here. What is going to be the best for this patient if we're talking about health? So for me, I chose a free gingival graft. And the reason that is because I needed to address the frenum attachments. I also wanted to address the lack of keratinized and attached gingiva. I want the patient to be able to brush freely without worrying about causing further damage. But I also like this too with a free gingival graft because there's almost no papilla at all between 8 and 9. That I felt with traditional connective tissue graft designs that the papilla would just disappear or become obliterated during the wound healing because frenum pools will tend to pull the papilla away. For me, the free gingival graft accomplished more goals than the connective tissue graft would. So this is what it looked like at 2 weeks. Now what you're going to see though, by the time it actually finally healed, you'll see the massive increase in keratinized and attached gingiva. The Frena pool is adequately addressed, but now you're going to see some unintended results, which is coverage of the implant components. So how does that happen? Well, that happens a lot in natural teeth. Matter of fact, if you're a periodontist or perio resident, or with any special interest in periodontics, you'll know about creeping attachment. So this is Mate's paper in 1976. They looked at recession defects 3 millimeters or less, where we got an additional bit of root coverage in the presence of good oral hygiene following a free gingival graft. So this is on, of course, was a study on natural teeth back in 1976. And now what we're looking at are some case reports where we're starting to see the same thing around implants. So even though we weren't expecting implant component coverage, we ended up getting it with a free gingival graft. But even if we didn't get implant surface coverage, I still would have done a free gingival graft anyway. So when we look at a similar case, this is implant number 23. You can see radiographically, everything looks great. But clinically, not so great. You know, thin tissue, even though it's keratinized at the collar, it's unattached. It's pulling away from the implant abutment and the implant itself. So this is what the patient looked like 1 and 2 years after a free gingival graft has been placed. And then I lost track of this patient because she drove in from an hour and a half away and didn't feel like driving in for a 3-year, photograph. So she took a bathroom selfie for me, and this is what it looks like at 3 years. So we get good stability with free gingival grafts around implants. So more cases for you on the left side here. And then, of course, if you're interested in how free gingival grafts work, this video is on my Instagram. It's probably all over Instagram because free gingival grafts are pretty popular nowadays. But anyway, they're very fun procedure to learn, very predictable, reliable technique to have in your bag of tricks at home. So definitely something that I would learn. So going back to aesthetics, though, let's switch from the lower arch to the upper arch. What are our solutions for an exposed titanium implant number 9? Implant's been there 20 years. Patient has no interest in removing it. Just wants the tissue to look a little bit better and healthier. Hurts when she brushes, so she avoids brushing. And of course, when she smiles, you can see it pretty clear as day. So once again, stressing health first and function and comfort, and then aesthetics. What do we do? So this is what the implant looks radiographically. I mean, look how big the implant is and look how long it is. Is it something that we really want to just remove? For me, I don't think so. I felt like if we were to remove the implant, we would possibly put the patient in a worse position. Number 2, there's no keratinized or attached gingiva. We have a thin biotype, high frenum attachment between number 8 and number 9. Facial position of the implant, but once again, the patient's really not interested in doing a whole lot besides just getting healthy and comfortable. So what I also like to do is kind of poll my friends and followers on Instagram to see what they would do. It was interesting whenever I posed this question that about half the people wanted to fix this implant and the other half wanted to remove it. Of the people who wanted to fix the implant, half of the 3/4 of the people selected a connective tissue graft over a free gingival graft. So naturally, I post these polls, and then I do the exact opposite. So we decided to keep the implant, and I placed a free gingival graft in its place, just to go against the grain and see what would happen. And what you're going to see here at 2 weeks is that we have pretty good healing of the graft. And then by 3 months, you can see that after the free gingival graft has matured, you can barely see any of the abutment at all. It looks pretty decent. I'm more than happy to do a gingivoplasty to smooth things up for her, but she seemed pretty content with this result, considering her before and her after. Also, of course, if they do end up deciding to remake the restoration, that you can imagine the result would look even better. So here we are. What about the subepithelial connective tissue grafts? So this, I love CT grafts for a number of different reasons. I especially love them for creating volume. So in a situation like this, the surgeon placed an implant for tooth number 6 and cantilevered over to number 7. The idea behind all that was to, preserve the papilla. Unfortunately, they still lost the facial half of that papilla, and there was a black triangle there as well. So what I like to do in situations like this is use a vestibular approach and harvest a tuberosity graft, very similar to what I showed you all earlier with the composite graft, except I don't go and take out any tuberosity bone. We only trephine out the soft tissue. So here we're utilizing the tuberosity connective tissue graft, and we're going to use some sutures to drag that graft into place. And we're going to suture it. And this is what it looks like at 2 weeks. And this is the final result here. We still have a little bit of a black triangle, but once again, what we were aiming for is filling the facial half of that papilla. So here's before, and here he is after. And that's 12 years apart, by the way. And unfortunately, this gentleman just passed away just a few months ago. He's a father of a close friend of ours. So, but it lasted him for a while. Sometimes when we place anterior implants, we have some marginal inflammation that just does not seem to want to go away. There's no cement under this thing. There's nothing, and we've already cleaned it out. Everything's very clean. We just need to change the gingival phenotype. So what we do in a situation like this, we also use a connective tissue graft. But one thing I always warn people, whenever you can, you want to leave the marginal tissue alone, because as soon as you touch an implant margin, if the tissue's too thin, it's going to want to recede, and you'll want to lose the papilla is the problem. So as much as we can, we try to tunnel. So here we've tunneled the facial aspect of tooth number 8. We placed the connective tissue graft, put in one suture, and you'll notice how the change in connective tissue and the appearance of the tissue is pretty dramatic from 2005 to 2018. All right, we're getting close to the end here, and I've got a couple of other neat cases, but here we have a case where the abutment of number 8 implant is exposed. This is the patient's 3rd restoration, and she just wants a solution. The dentist who's done this 3 times has implored us not to recommend another restoration. So I told them no promises, but we'll try to see what we can do surgically, since we do have a soft tissue defect anyway. The gingival margin looks a little bit unusual to me. So what we decided to do was, of course, poll Instagram again here in a second. But here's the implant. Good bone around the implant, but you can see that we have an issue here. So we have gingival recession. The patient does not like that. We actually do have adequate keratinized and attached gingiva. There is no frenum pool in the area, and there is a small concavity at the distal facial line angle of that abutment. So restorative treatment is not an option. So what do? Go to the poll. My suspicion here, because the recession on this case is the exact same as the other case where we had recession on an implant. What's kind of funny is that 89% of the people now want to fix it, and 11% of the people want to take it out. My suspicion is that the reason that is because there's more keratinized tissue, so the implant actually looks healthier. But once again, as far as treatment solutions, 3/4 of the people favor a connective tissue graft. So in a situation like this, I did the exact same thing. So I did a connective tissue graft. So when we harvest the connective tissue graft, I generally like to go through a single incision in the palate. This is A sharp dissection just underneath the epithelial layer of our connective tissue harvest. And then what I like to do is just use this is just a Pritchard elevator. Then we're going to elevate the tissue off of the palatal bone. I like to go full thickness for me. That way I get a nice thick graft. And then we sharp dissect out the rest of the graft material from the palate. And what's neat about this, and I think we have a nice thick specimen here. When you look at the palate when we're done, you can see a very nice and neat incision. You can put one little anchoring suture around the teeth, or to be honest, sometimes I leave it unsutured. So here, just like when we're treating natural teeth, we're going to use a burr to establish a flat or concave surface on the abutment. This is a tonal flap design. So we're going to utilize the sutures to drag the graft material, the connective tissue graft, over the implant surface. I always jokingly tell my pinhole surgical technique colleagues that this is the no-hole surgical technique. And then, of course, we just suture. This is just chromic gut sutures. And this is what it looked like at 3 weeks. And then as this thing matures at a year, you'll notice that we get coverage over the abutment. The key point here is we flatten that abutment to where it's pretty flat. So we encourage that tissue growth across the flatter or concave surface. Here we are at a year. So the last topic, and I'll probably go about 10 more minutes and we'll be done, is the vascularized interpositional connective tissue graft. This is also something I think all periodontists, or people who have an affinity for oral surgery and implants should learn. What the VIP CT grafting technique is, it's intended to create massive volume. So in a situation like this, we have a concavity over number 7, which is the pontic, but will soon be an implant. What we're doing here is we're harvesting a connective tissue graft like I just showed you. But as we release it from the posterior portion, we leave the blood supply and the anterior portion of the donor site completely intact. We leave it intact so that we can maintain the blood supply so that we get less volume shrinkage. And that's really important, especially when we're trying to grow tissue. So here we're going to, the next step here is we're going to drag that connective tissue graft. I'm going to tuck it under that lingual flap and then drag it over to the facial, suture it. And as we evaluate this, you can see how nice and neat and clean that procedure is. So it heals up pretty unremarkably to get us that big volume for our implant. So how does this work when we're talking about soft tissue rescue? So the advantages, once again, is that it maximizes tissue volume without shrinkage. So in a situation like this, I'm going to go over this with my last 2 cases. This is my treatment of choice when it comes to soft tissue implant rescue. So to make a long story short, this is Katie. Katie is a dental assistant who happened to be her employer's guinea pig for his very first implant that he placed, which was an immediate implant for tooth number 9. As we go through this, you're going to notice that number 9 eventually hit tooth number 10, the lateral incisor. She lost both teeth, and she eventually went to an oral surgeon who had to do multiple grafting procedures in order to be able to place 2 implants for the central and for the lateral. So here's where she's at. When I asked Katie what her goals were, and this is her smile, she wanted 2 things. One is that she wanted the gingival margins of 8 and number 9 to be even. And for me, I said, hey, you know what, that's a pretty reasonable goal. I think we can get 2 millimeters of coverage. That's not a big deal. And I asked her what else she wanted. And she said, I only want one other thing. It's a pretty simple request. I want the papilla back. That, of course, is a challenge. So I told her no promises, but if anything is going to work, it's going to be with this VIP CT graft. So here to walk you through Katie's mishaps. Here's her original implant, hit tooth number 10. Number 10 got endo, then ultimately failed. Here's the implant. You can see it's placed way too far to the facial and, of course, into the other tooth. Eventually lost both teeth, and now she's in a situation where she has 2 integrated implants and a provisional restoration, which she hates. So what we're going to do here is a VIP CT graft. I'm going to throw this chart up here to let you know how hard her case really was. So you can see how apically placed these implants are. Very, very far apically. Number 2, there's 2 implants. So when we look at the size of the average papilla between various restorations, we will see that an implant next to an implant yields the smallest papilla. And in Katie's case, she even has a negative papilla. If we would have went implant to ponic, you pretty much gain an additional 2 millimeters of tissue of papilla height. We probably couldn't do that here now because of how big her crown height space is, especially with a cantilever. Maybe the force factors aren't a good idea. So we decided to go ahead and still treat both implants and restore both implants. So to remind you, there's 4 factors affecting implant aesthetics: the existing gingival levels, which are not good here; the implant depth and position, which is not good here; response of the tissues to the implant procedures. It's not Katie's fault, but also not very good. And then, of course, management of the tissue with the abutment in the crown. And she's got provisionals she doesn't like, so also, not very good. So we're in a little bit of some trouble here. So we've taken her provisionals off, and you can see what she looks like. Once again, no papilla, maybe even negative papilla between the central and the lateral. So we've done this VIP CT graft, taking it from the left side of the palate and then just flipping it over. This is her video. I don't know, for whatever reason, I must have been bored that day. I got out my old camcorder and recorded this. But here we're just making a slit in the VIP CT graft material. And what we're going to do is we're going to slide it over a very, very tall healing abutment, which is going to serve as our tenting screw or tent pole to support the papilla. So that's what we've done here. Fast forward this. And you can see how much graft material we have. I mean, it's folding over the healing abutment, and we have plenty to go over the facial aspect. In hindsight, I think one of the things I have considered was a veneer graft with some particulate material maybe over the facial aspect, but I didn't think about it at the time. Here we're going to suture everything up, coronally advance everything. And then we relined the provisional. I was supposed to coordinate with her dentist to get him to remake her provisional, but this was done on a Wednesday, and Wednesday was his golf day, so we didn't get a chance to do that. So I just relined it myself. At 12 weeks, you can see we looking a lot better as far as the soft tissue goes. And then I lost track of Katie because she moved, got married, and had a baby. And she did come in 5 years later so that we could take a photo. And this is what she looks like at 7 years now. So not too shabby, but not perfect either. So with our last case, and I'll close with this. This is Lucas. He came into us because he had 2 implants placed by his surgeon. And this is what he looks like when he smiles. You can see the 2 healing abutments. He has a high smile line, maybe even a gummy smile based on his very short square tooth morphology. This is what he looks like with his cheeks retracted. But we have no keratinized or attached gingiva. We have high freedom pulls, thin biotype. Implant positions are not good from a inciso-apical perspective. but this is what he looks like. So what are we going to do? We're going to do the same thing. We're going to propose doing a VIP CT or soft tissue graft. This is what he looks like with the flap reflected. You can see we have a little bit of crystal bone loss around the implants, but for me, not enough worth, trephining the implants out or removing them or whatever, torquing them out. I just did not feel that was going to be our best option given the success of some of the soft tissue grafting procedures that we've had. So here we've done a double VIP CT graft, one from the right, one from the left. We're going to flip those grafts over the recipient sites, which is the implants. You can see the occlusal and the facial views here. That's what it looks like finally sutured. 2 weeks post-operatively, you can see everything's healing up pretty well, all things considered. You can see how much volume we have, a ton of volume. You'll also notice between mesial to number 8, there's a little bit of graft necrosis, which I think that can be expected when you're dealing with the graft this size. This is what the patient looked like at 8 weeks, and at 12 weeks, with his provisional in, I can see here that I didn't really like his smile that much because during all this, we had to pull so much of his mucosa over. Even though the implants are covered and everything, and we got to have good coverage, the lack of keratinized and detached gingival really looks horrible to me when he smiles. This worked out really good because, for me, what I recommended we do is a free gingival graft, which is rare for me in the maxilla, but that's what I recommended at the time. And he said, "Oh, perfect," because this spot on the palate right here has been bugging the heck out of me because it's so thick and bulbous. So I use that as my donor site. And the other thing that I wanted from him too, I wanted him to consider doing an aesthetic crown lengthening before we do his final restorations. And he's still considering it, but I noticed that if we were going to do a aesthetic crown lengthening, we would definitely create a mucogingival deficiency for him. So that's the other reason for the free gingival graft. This free gingival graft is interesting because I call it the Oklahoma graft because of its shape and resemblance to the state of Oklahoma. And you'll see that we sutured it into place on the facial aspect. You can see what it looks like from the occlusal view. This is what it looks like in the final healing. And he's still thinking about the aesthetic crown lengthening, so he's just committed to provisional restorations for now. I hope he makes a decision soon because this has been 3 years. But this is what he looks like. It looks pretty good. And you'll notice a difference in his before and his after, as well as in his smile. You'll notice a pretty big difference there. So here's him before, and this is Lucas afterwards. So with that being said, 6:22, and remember, I'll be around for a few more minutes to answer some questions, but if you need to get a hold of me, just hit me up on social media and we'll get it all answered. So thank you all for your kind attention and for the invitation. It's been a real pleasure.
Dr. Wong, thank you so much for such an informative and enjoyable presentation. You've highlighted really beautifully that implant dentistry is not just putting a metal screw into the jawbone and asking the lab to fabricate, a white crown, but that the attention to detail and the development of the pink aesthetic plays a really crucial role in the success and the longevity of the dental implants. I quite enjoyed how you showed the various approaches to rescuing the ailing implants and restoring health in the aesthetics. I'm going to now pass on to the moderators because we have a few questions coming through. Actually, we have quite a few questions. So please take over.
Yeah, bring them on. Let's answer them.
Thanks a lot, Dr. Wong. Chris Dare here, second-year perio resident at the U of T. Hopefully, we'll all be able to rescue and manage our cases better in the future after your lecture. I just have a question here for you. You showed a case with the implant, like kind of poking through the bulk mucosa. The question was, what are your thoughts on the maxillary frenum pull in that case?
If the implant's sticking it up through the buccal mucosa, I don't like maxillary frenum pulls personally, so I usually try to address that. If it's directly, like if it's in an area where it's not even going to be restored, then I'll use a free gingival graft to cover the concavity that'll result from removing the implant, first of all, but also it addresses the frenum attachment simultaneously. So I hope that answers the question. If it's not too egregious of a facial positioning, then we'll try to save the implant. But sometimes we just can't do it.
Thank you very much.
All right, thanks, Dr. Wong. So another question here from our audience members. Can you describe your technique for harvesting a tuberosity CTG?
Super easy. I showed two different ways, actually. So number one, if you have a trephine, it's easy. You just use your trephine and you just hold your trephine drill parallel to the second molar and just drill straight in to the appropriate depth and remove it. But if you don't have a trephine, all you do is you grab a 12B blade and you just go to the tuberosity and just remove, basically by external bevel incision, just remove it, and then use a round diamond burr to take off the epithelium, and you're done.
Cool, thank you. So I'm Lilia, first-year resident at U of T, and we have another question here. What kind of burrs are used for bone perforation prior to grafting?
For bone perforation, okay, so that's a surgical length, usually round. I like diamond burrs. For me, I use a medium, usually a medium or a fine diamond is what I like to use. As far as the size, they'll vary, but I would say my most common size is a number 4 or a number 6 round diamond. And some people don't like diamonds. I do. I don't like carbides because they tend to grab and flick the bone a little bit too much. So for me, personally, I like a number 4, number 6 round diamond.
Great. Another question here for you. Does creeping attachment with FGGs occur even without involving the margin during surgery? You showed that great case at the beginning there with the FGG at the mandibular incisor or implant.
Does it happen even without surgery? Is that the question?
Without surgery involving the margin? Could you place your FGG?
Oh yeah, it does. So my very first case I showed, I did not even involve the margin. I put it at the mucogingival junction, and it still crept up. So it can. I never promised that. It's strictly a phenomenon that does happen not on more than occasion. It happens quite a bit, but just like with root coverage and free gingival grafts, I just try not to get my patients' hopes up too high.
Perfect. And sorry, I forgot to introduce myself last time. My name is Sean Robinson. I am also a second-year perio resident at the University of Toronto. The next question comes from an audience member that has had a few patients who had connective tissue grafts completed on their lower anteriors, not implants, but they never had the frenum removed. Now they're saying there is recession again. Now, is it common to leave the frenum when grafting, or does it depend on the case or the patients that you see?
Most of the time people do release the frenum, but they usually do it internally. On occasion, so if you follow like Dr. Bobby Butler's work, he's also a University of Oklahoma graduate like me, he does it externally, but it's almost always addressed. Now, it won't address it as effectively and as definitively as a free gingival graft because you're not actually removing it. So it's addressed either internally or externally, and it'll be relieved, but probably not removed.
Thank you. We have another question. Do you treat the implant surface before placing the graft?
I do, actually, and that's a great question because I keep forgetting to put that slide in. I typically will treat the implant surface if it's exposed with just a tetracycline pumice. So I'll just crack a tetracycline capsule, mix it with saline, or sterile water, and just make a tetracycline slurry or pumice, and just burnish the implant surface for about 4 minutes. And that's all I do.
Great. Another question here. Do you have any go-to references for your vestibular approach? And they give the example of a case where you showed the tuberosity graft inserted into that.
Oh, yeah. Yeah, so look up anything by Jay Siebert or Henry Salama. Those were some of the original papers where they, you guys would probably be familiar with the Siebert class 1, 2, and 3 defects. Look up their work. They do a good job of explaining that.
Perfect. Moving along quite well. Thank you. So next question, do you use short implants? And kind of an additional question to this, what do you think of the pinhole technique, and do you use it?
First question, short implants, I do. The shortest that I typically go, though, is like 7.5 millimeters. I haven't gotten into anything shorter than that yet. I think the literature does positively supports the use of shorter implants when it comes to avoiding like sinus grafts and things like that. And I'm not sure, you guys may have to correct me, I'm not sure if the literature is very clear on how that short implants with a really tall crown height space when there's actually quite a bit of vertical bone loss. So that one I'm not sure, but I use quite a few short implants to avoid having to manage the sinus. As far as the pinhole surgical technique, I use the pinhole surgical technique flap, but I don't use the technique, no, because it utilizes resorbable collagen membranes, which for me, and I've taken the course, I've been officially certified or whatever, but the results were short-lived for me in my practice. So I ended up having to redo a lot. But the flap management design is good.
Thank you. Comparing ADGs to FGGs and CTG, do ADG have comparable longevity with the other two types of grafts? And aside from eliminating the need for two procedures, is it more preferable to use ADG or FGG and CTG?
For me, nothing lasts longer than a free gingival graft, and it's not even close. For the connective tissue graft and the ADG or acellular dermal graft, I get comparable longevity, but nothing lasts longer than a free gingival graft.
Great, thank you. Another question here for you. How do you prepare your FGG graft bed?
Super easy. I do I cut across the CEJ, the tooth that I'm treating. I just cut across the papilla at the same height, making horizontal incisions. And then I just, I choose a line angle of the, wherever I want to go. So let's just say 24, 25 is the teeth that I'm treating. I'll make a horizontal incision in the papilla between 24 and 25 at the level of the CEJs typically. Carry that to the lateral incisors. And then I drop 2 verticals, and then I use a fresh 15 blade to sharp dissect and a partial thickness flap. I remove the entire midline freedom, and that's my bed.
Perfect. And another question regarding postoperative. Do you ever use a dressing like Copac? And what are your postoperative instructions following these types of surgeries that you inform patients with?
Yeah, I don't use Copac. I've used it one time ever, and that was when I was a resident, and I haven't used it since. Lots of people love them. Some patients claim to like them as well because it covers the wound. I personally don't use them. Postoperative instructions. The big one is for the patients to not move their lip. We don't want them to move their lip or contact or touch it or show their friends and family or coworkers. I keep them on a soft diet for 3 days and then eat whatever they want after that. I tell them not to bite into anything like an apple or a sandwich. until at least I see them next, which is 2 weeks later for the suture removal. Outside of that, we put them on an analgesic for pain, antibiotic, just amoxicillin, put them on an antimicrobial rinse, and that's really it. That's really it. I do make a suck down vacuum form retainer to cover the palate to help ease the tenderness there, and I tell them to wear it as needed, as they want.
Thank you. So someone was wondering how long the volume can be maintained after connective tissue grafting, and if a second or third grafting is needed over time to maintain the volume, and what's the success rate?
Yeah, success rate for a connective tissue graft is high. I've been in practice 18 years. It's typically it stays around, especially if you use a tuberosity graft, it stays around forever. It's not moving anywhere. Connective tissue graft for volume, it's hard to say because I haven't, being a periodontist, I don't get to follow people up like that all the time. But I can, for me, I don't worry about the volume with a connective tissue graft. I would actually worry more about the root coverage part if it was for root coverage.
Great. And one final question here. When you do your tetracycline pumice, do you rinse afterwards, or are you worried about tissue burn?
Oh, I don't care. Yeah, you just rinse afterwards. Yeah. There's no worry about burning the tissue with the pH or any of that stuff.
Great.
Not an issue. Is that it?
Okay, so I'm can you see me? So I'm back. Dr. Wong, I've actually been a fan of your social media account on Instagram for a while. There are some pretty amazing photos and really great discussion points. So if anybody here has social media, you should really check out his page. You're gonna gain some valuable clinical tips and probably tips on how to bench 100 pounds or 500 pounds. So you mentioned that you prefer to perform the soft tissue graft or augmentation before ridge augmentation, before the hard tissue. Do you find that, is there any limitations in flap mobility during the ridge augmentation after a free gingival graft is performed?
Yeah, so if you make your free gingival graft too large incisal-apically, then that can inhibit graft mobility, specifically your ability to advance the flap over the graft material in the membrane. So that's one key thing is you don't want to make it too tall. Otherwise, it's great. It actually makes ridge augmentations tremendously easier for me.
Thank you. Well, I think we've exhausted your time tonight, so I will just conclude by thanking you for really taking the time out of your busy schedule and being here with us tonight. It was really a pleasure listening to you talk. So thank you also to our moderators as well as our participants who have joined us tonight. We've had a really good number of turnouts. If you have any further questions, please contact Dr. Wong through his social media page. And then if you have any questions about the OAK seminar series, I am going to put up, Dr. Wong, can I take over the screen?
Yeah, absolutely.
And I'm going to put up there we go. So this is the email address that you can write to. But before we bid everybody good night, I'd like to invite you back in 2 weeks to have another treat with Dr. Ziv Simon coming from Beverly Hills, California. He's going to be talking about new strategies and tactics for aesthetic zone implants. And due to popular request, please note that the timing will start at 6:30 p.m. and not our usual 6 o'clock. So please register ahead of time. We hope you will join us again. Good night. Thank you again, Dr. Wong, and have a good week, everyone.
Thank you, everybody. Have a good night.